All right, welcome. This presentation introduces the Vulnerability Curiosity Integration Model, or what I'm calling VCIM, a seven lens framework for couples and family assessment and intervention that I developed as a student clinical practitioner at the Wisconsin School of Professional Psychology. But this model is grounded in Bitter's 2021 integrated process from Chapter 18 of the Theory and Practice of Couples and Family Counseling. The Bitter argues that integration in couples and family work is both attractive and can be dangerous. It is attractive because families present with multiple overlapping issues simultaneously. It becomes dangerous when it collapses into technique collection without a coherent theory of change underneath. So, VCIM is my attempt to answer the challenge. Uh, it is organized around two relational disciplines, both vulnerability and curiosity, and structured through the seven lens assessment that's drawn from the meta framework tradition described in the chapter. So integration fails when it becomes technique collection. A little structural work here, some narrative language there, a homework assignment at the end, with no clear theory of change unifying the work. Families deserve coherence. They do not benefit from a counselor who is improvising theoretical eclecticism while they are in pain. So, Bitter offers a disciplined alternative. He argues that every counselor needs a foundational model that fits their own values, presence, and their way of being with people. From that foundation, integration models need to be coherent and purposeful rather than random. As four integrative movements organize the counselor's work. So the forming of a relationship, conducting assessment, hypothesizing, and sharing meaning, and facilitating that change. So these are not sequential steps performed in order. They are a recursive process that continues throughout the therapeutic relationship. So here is the VCIM in brief. The core posture is vulnerability with safety, curiosity without premature judgment, and accountability without contempt. These three phases structure how I enter the room, how I track what is happening between people, and how I hold both compassion and responsibility simultaneously, at least to the best that I can. The theory of problem is simple. Families get constrained by repeated protective sequences that once made adaptive sense, but now block belonging, truth, leadership, growth, and repair. These are not character defects. They are survival strategies that have outlived their usefulness. The theory of change is equally direct. Change occurs when the counselor joins well, maps the sequence, invites vulnerable truth, co-constructs meaning, and practices a new sequence with the family. Change is not primarily cognitive, it is practiced, relational, and most of all embodied. The ethical stance holds virtue principle, legal, and participatory ethics together. That is consistent with Young, Kleist, and Bitter's multi-ethical integration model in Chapter 4. So before describing the model's structure, I need to say something about its personal foundation. So VCIM did not emerge from a literature review. It emerged from my story. My history includes my military service, addiction and long-term recovery, includes incarceration, my faith conversion, education, marriage, fatherhood, ministry, and my clinical training. These experiences have made it difficult for me to reduce people down to their symptoms, their past mistakes, or the diagnoses on their chart. I know what it's like to be seen as only a problem within the systems. Because of that, my clinical reflex is to look for the person beneath the presenting problem, the pain, the courage, the shame, the spiritual hunger, and the relational longing. Vulnerability for me is not just a technique, it is a posture carved by life. And curiosity is not passive neutrality, it is the discipline of slowing judgment long enough to ask, how did this make sense before it became destructive? Vulnerability in VCIM means telling truth within a frame that honors dignity. Curiosity means active inquiry that seeks understanding without surrendering ethical responsibility. Together, they allow the counselor to hold both compassion and accountability, and to protect the family from the counselor's own need for premature resolution. So VCM, it draws from more than two theoretical traditions as required by the integrative practice assignment here. So the 5 pillars are Adlerian family counseling. Adlerian thought offers encouragement, social interest, purposefulness, and family constellation. In practice, it all comes down to serving what does the goal of the behavior serve? How can mistaken goals be redirected towards connection and contribution? This fits VCIM because it assumes meaning even in misbehavior. So it's also attachment informed and emotionally focused work. Beneath defensive strategies, whether it be anger, withdrawal, control, perfectionism, they're all frequently attachment fears. Fears of abandonment, not mattering, being exposed, or being trapped. VCIM uses vulnerability prompts to help family members speak from softer primary emotion rather from defensive protest. So the structural systemic counseling aspect here. So families need organization. Need roles, boundaries, subsystems, coalitions, and routines can either support health or constrain it. VCIM uses structural observation to ask who carries too much, who has authority without relationship, what sequence repeats under stress, and also what are the cultural subjectivities and objectivities that exist within those frameworks. So narrative and postmodern collaboration. VCIM uses a tentative not knowing stance throughout. It externalizes problems when helpful, invites clients to correct the counselor's hypothesis, and attends to culture, power, and marginalized voices within the family system. So the solution-focused end of this and cognitive behavioral practice, families need a little bit more than insight. They need doable next steps, measurable goals, behavioral experiments, and one different response to practice, maybe this week. So assessment in VCIM is organized through 7 lenses drawn from the meta framework tradition, provided to us by Bitter and Sperry. Each lens asks a distinct orienting question and is rated 0 to 4, not as diagnosis, but as a conversation prompt to structure clinical attention. So, organizational lens. What structure, boundaries, leadership roles, alliances, routines, and power engagements or arrangements, excuse me, are maintaining the problem? The developmental lens. What life cycle transition is the couple or family trying to make, and where has the growth become blocked? The cultural lens. What cultural narratives, social locations, and community pressures shape the problem and the available solutions? The mind lens. What thoughts, emotions, meanings, fears, internal parts, attachment wounds, or family of origin templates are constraining the system? Gender lenses. How are gender expectations, patriarchy, matriarchy, role strain, caregiving, labor, sexual identity, or power inequities influencing the system? Biology and wellness lens. How do sleep, pain, substance use, medications, trauma arousal, sexual health, illness, and nutrition affect the relationship? And the spiritual lens. What sources of meaning, faith, forgiveness, calling, moral injury, despair, or hope are active? What spiritual constraints are present? So integration improves the assessment because it prevents the counselor from mistaking a partial truth for a whole truth. A structural assessment may reveal unclear boundaries, but it may miss grief. A spiritual assessment may reveal hope, but it may miss spiritual bypassing. The 7 lenses keep the counselor asking, what else might be true? So the relational sequence map is used when a couple or family is stuck in blame. The clinical goal is to locate the shared pattern rather than identifying a villain. And this shift is one of the most important things a counselor can do early in sessions. The map works through 5 steps. For each step in identified sequence, the counselor and family collaboratively explore what happens, who does what each person is protecting, what the sequence costs, and what an alternative response might look like. The power of this tool is that it moves the conversation from you did this to me to here is what happened between us, here is what each of us is trying to protect, and here is what it costs our relationship. This is the structural system pillar of VCIM, seeing the relational field, not just the individual actor. These 6 prompts are the clinical heart of VCIM. They are designed to interrupt defensive, protest, and invite primary emotion, the attachment need beneath the behavior. Each one is crafted to slow the conversation, reduce contempt, and create a moment of genuine contact. So the prompts are, before you tell them what they did wrong, what did you long for in that moment? What are you afraid would happen if you stopped protecting yourself in this way? When you withdrew, or pursue, or criticize, fix, shut down, or control, what are you trying to protect? What would you want them to understand about your story before they respond? What is one question you could ask that would help you understand rather than win? What is the smallest truthful sentence you can say without attacking or disappearing? These prompts are not scripts to be delivered mechanically. They are invitations to a different quality of contact. The counselor's own non-anxious, curious presence is the primary intervention here. The prompts give language to that posture. So the tentative shared hypothesis is the integrative move that translates assessment into meaning. It follows Bitter's 2021 guidance that the counselor's hypothesis should reduce shame, clarify responsibility, and point towards practice. So the template reads, I may be wrong, so please correct me. Could it be that when blank happens, blank protects themselves by, well, protects themselves by, this pattern may have helped the family survive, but now it seems to cost you. The I may be wrong opener is not rhetorical hedge. It is a structural commitment to collaborative meaning making. The family's authority over their own story is non negotiable. The counselor offers hypotheses, then the family corrects them. The three principles govern the hypothesis. It should name the pattern without naming a villain. This reduces shame. It should acknowledge each person's protective move without locating the problem in only one person, clarifies responsibility. And it should end with a first experiment, one different response, one doable next step. So that's the behavioral part of it. All right. Insight is necessary but insufficient. Families need to practice a different sequence, not just understand it. VCIM includes 6 structured change experiments, each targeting a different dimension of the relational system. So, to begin, we'll say that a 10-minute curiosity conversation gives each person 5 uninterrupted minutes where the listener may only summarize and ask one curious question. This bundles the listening skill that is foundation of all the other experiments. This was kind of adapted from Rogerian theory and others. A lot of them share the same way of listening. The repair attempt practices, or the repair attempt practice gives a specific language scaffold for returning after conflict. I got defensive. What I meant to say was blank. What I hear you needing is. It teaches repair without requiring the conflict to be relitigated. The parent leadership meeting restructures the parental subsystems. Caregivers meet for 15 minutes without children to decide one boundary, one encouragement, and one shared message. This directly targets structural systemic issues. All right, the vulnerability ladder invites each person to name a safe truth, a stretch truth, and not yet truth. Only the safe or stretch truth is shared in session, protecting the client from premature exposure. The wellness stabilizer asks the family to choose one bodily stabilizer for the week. Sleep, medication, follow-through, movement, sobriety support, nutrition, or medical follow-up. This activates the biology wellness lens. The meaning and forgiveness reflection offered only with explicit consent, or rather consent, invites family members to identify what faith, values, or conscience calls them toward, without using spirituality to bypass accountability. So integration increases ethical complexity. When the counselor draws from multiple models, the ethical burden increases. The counselor must be able to explain the purpose of each intervention, use them with competence, and avoid experimenting on families without consent. So the 7 ethical guardrails of VCIM are do not use vulnerability prompts when coercion, violence, retaliation, intoxication, or acute instability are present. Safety assessment precedes relational depth work. Do not impose spiritual language. Ask permission before spiritual resources or faith-informed reflection. Spirituality has been used to shame, silence, and bypass accountability. A counselor must not replicate this. It is also good to ask what words are being used, even what they name God. So do not interpret medical symptoms beyond competence. Refer or coordinate care when biological concerns are present. VCIM is not a substitute for psychiatric or medical assessment. So next one, do not allow one person to become the designated problem without assessing the relational field. The problem lives in the sequence, not only in one member. Do not use formal measures as verdicts. Use them as conversation starters and discuss them collaboratively with the family. And that's a Sperry adaptation there. Use supervision or consultation when countertransference, attraction, contempt, rescue, impulses, fear, over-identification become active. Countertransference is always ethical data. So that's from Solomon and Siegel, another text. Document. The shared hypothesis, safety assessment, client goals, intervention used, homework assigned, and plan for follow-up. All right. Integration improves the assessment because it prevents the counselor from mistaking a partial truth for the whole truth. This is the core epistemological claim of VCIM. Initial assessment in VCIM covers the presenting complaint in client language, safety screening, family structure and genogram, life cycle transition, cultural and spiritual context, gender and power dynamics, individual distress and wellness factors, and the identified repeated relational sequence. Ongoing assessment continues throughout treatment, client feedback and outcome tracking session, observation and sequencing updating, revision of the shared hypothesis, evaluation of formal measures as conversation starters, referral and coordination when indicated, and supervision and consultation as ethical data. Formal measures can be used, but they should not replace clinical humility. Sperry emphasizes the value of multiple methods, self-report, observational approaches, and clinical judgment. VCIM frames all formal results as conversation starters, not verdicts. This is especially important with culturally diverse families and families that have experienced clinical systems as punitive rather than helpful. All right, so adequate documentation is both an ethical requirement and a clinical tool. VCIM documentation captures 7 elements after each session. So utilizing this wherever is helpful within your note. Presenting concern in client language. Use the client's own words, not clinical paraphrase. Safety and ethical considerations. Document any active safety concerns, ethical tension, or guardrail activations. Observed sequence. So describe the relational pattern observed or reported in the session. So primary lenses active. Note which of these 7 lenses were most clinically active this session. Tentative shared hypothesis. State the working hypothesis as currently understood. Update new information as it emerges. Intervention or experiment assigned. Specify what was introduced, practiced, or assigned. Outcome review plan. So document how the change will be tracked and what constitutes progress for this family. So this process, as I'm sure some of you were aware, you can fit very simply into a SOAP note, a DARP note, however you report things, it's all there. So This fits the APA Ethics Code 6.01. That just about does it for us. Added one additional text than I typically used, and that was the Countertransference in Couples Therapy by Siegel. And a little bit of the personal work that I did with the formation of the VCIM model. All right, thanks.